Tantor Audio, a division of Recorded Books, presents Mindfulness for Borderline Personality Disorder. Relieve your suffering using the core skill of dialectical behavior therapy by Blaise Aguirre, M.D., and Gillian Galen, PsyD. Narrated by Laura Copland. Introduction. The suffering that underlies the struggle with borderline personality disorder, BPD, is made palpable in these thoughts from Sylvia, a young woman who feels that she has run out of options. If life is a long string of painful moments and all you do is die at the end, why can't I just die now? Why does everyone want me to live when my life is so painful? That's why I want to kill myself. I won't do it because it would devastate all the people that I love, but that's why I need your help. I really need to find a way to cope when things are so hard that I just want to give up. I've been trying to stay present, just like you suggested, but it's so hard because wanting to die consumes me so much. I mostly need help finding a reason to live. Some days I can almost see hope. I need your help finding more hope. If you suffer from BPD, you may be able to relate to Sylvia's struggles. BPD and suffering. Using mindfulness to free yourself of the suffering resulting from BPD is a difficult task, in large part because it requires attending to what's going on in your mind. We asked Lauren, a 20-something-year-old woman with BPD, to consider the difficulties involved in establishing a mindfulness practice. She wrote, "Why the resistance? It is impossible for me to shut my thoughts off. It only makes me more angry because I think, stop thinking, and then stop thinking about not thinking, which leads to, why is it that I can't not think? And then I go back to, here I am, thinking again. And then I want to hit something because I'm so frustrated with myself. And even if I were to think about something specific, like, oh, look how beautiful the trees are, in the background my brain would think about something else. And then behind all of that, I'd think that my thoughts shouldn't be wandering off, that I need to focus. Do you see? Silence is hell. I can't fall asleep without noise because the noise is the only thing that stops me from thinking. I listen to the TV every single night to fall asleep. If I didn't, I'd never fall asleep. Even as I sit here and write, I'm thinking about the words I'm typing, but I'm also thinking about other things in the background. The more someone tells me not to get caught up in my thoughts, the worse it is, and the more frustrated I get with myself. A critical breakthrough in the treatment of BPD came with the development of Dialectical Behavior Therapy, DBT, by renowned psychologist Marsha Linehan. The explicit application of mindfulness to the treatment presented for the first time a way to get people with BPD unstuck from their judgments and intense emotions that lead to suffering. Mindfulness also provides a way to help people who are suffering from BPD to be more effective in applying other useful coping skills in the midst of emotional pain, because mindfulness teaches noticing the emotion without reacting in ways that perpetuate suffering. Through this book, we hope to expand your knowledge and practice of this core DBT skill. We will look at the practice and science of mindfulness and teach you how to apply it to your BPD symptoms. Mindfulness and suffering. For Lauren, the idea of slowing herself down enough to pay attention to her thoughts was intolerable, because it would mean paying attention to all of the pain and suffering in her life. Why would she want to do that? In large part because research shows that avoidance of suffering leads to more suffering. Numbing yourself out against the torments of life is a solution, but not a very effective one. Lauren would rage in the context of feeling misunderstood, particularly during an argument with someone she deeply cared about. Without mindfulness, she would say hurtful things and sometimes become self-destructive and suicidal. Her mindfulness practice consisted of noticing her anger and developing the ability to describe her experience. I am feeling really angry, hurt, afraid that you are going to leave me. Recognizing these emotions without acting on them could slow her down enough to allow her to choose her behavior, rather than act mindlessly and make an already miserable situation worse. Rather than say something hurtful, she could use mindful awareness to choose to say or think, I am too upset to talk about this right now. I don't want to do something I'll regret later. I need to take some time to get present and out of my head. Such an approach would also mean that she would have time to validate her experience as authentic and understandable, rather than move into behavior that could bring her even more shame and anger. BPD and mindfulness. When mindfulness takes hold and the practice is established, suffering begins to melt. Patrick, a young man with BPD, had struggled with various forms of treatment before we introduced him to the idea of mindfulness and how he could begin to get out of his head and pay attention to the reality of the world around him. Desperate to try something new, Patrick threw himself into the practice. After 3 months, he came to a session and said, I have lived in the same house for 20 years and never noticed just how beautiful my neighbor's garden is. I see so much of my neighborhood that I never realized was there, and people say, hi. I think the mindfulness practices have been helping me a lot, and I know I have a long way to go in terms of really incorporating the techniques into my day-to-day life. I've noticed that my overall anxiety has gone down significantly in the past several months, but it hasn't gone completely. I've become more aware of many of these situations and the impact my anxiety has on my life and my relationship with my girlfriend. I've also noticed that I'm not as depressed as I was over the summer. We hope that in this book you will find the wisdom and willingness to practice mindfulness, not only in the moment of struggle, but also as a way of life. And we hope that in doing so, this practice will lead you to the realization that suffering is neither permanent nor inevitable, and further, that paying attention to things as they are is a path to happiness. A quick guide to this book. With this book, we aim to show you the wisdom and power of mindfulness as a way out of suffering. We have divided the book into 4 parts. Part 1 provides you with an overview of borderline personality disorder and of mindfulness. We review the history of BPD and mindfulness and the ways in which these terms are defined today. Here and throughout the book, we include many stories and insights that people with BPD have shared with us, highlighting their personal struggle and their own introduction to mindfulness. In Part 2, we guide you through the practical application of mindfulness. We expand on this core skill of DBT and introduce a number of other mindfulness practices. You will learn how to develop your own mindfulness practice so that you can use these newly learned skills as a way to take control of your mind and to stop being tossed around by your thoughts and feelings. In Part 3, we explore the lived experience, looking at each symptom of BPD and teaching you specific ways in which you can practice mindfulness to reduce your suffering associated with these symptoms. You will listen to case vignettes to see how this is done, and you also will learn to recognize the challenges that you may face and to avoid typical pitfalls that you may experience along the way. In the final part of this book, we look at the journey that awaits you on your mindfulness path. We explore the impact of how you tell the story of your life and show you how you have the power to change your narrative, particularly when it causes you to suffer. Making it useful. Mindfulness practices. Developing new habits and ways of using your mind can be difficult. To help you develop an understanding of mindfulness and how to use it in your life, we provide illustrative examples throughout the book. We have also highlighted many mindfulness practices. We ask that you bring willingness and an open mind to these practices. Remain curious and take time to observe your experience after doing the practices. Some will be easier than others. Find what works for you. Remember that the more you practice something, the better you will get at doing it. The exercises in this book are meant to be practiced over and over again, and when you are mindful, you will find that you can repeat practices many times and have different experiences. This book is meant to be a guide to not only teach you about mindfulness, but also teach and support you in an ongoing mindfulness practice. We hope you find each chapter informative and instructive. If we have accomplished our goal, by the end of this book you will have set foot on a mindful path and feel inspired to continue to practice mindfulness as a way of not only decreasing your suffering from BPD, but also experiencing joy and living your life. Part 1. Defining Borderline Personality Disorder and Mindfulness. Chapter 1. Borderline Personality Disorder. If you are like many people who live with borderline personality disorder, you know what it's like to be tossed about by your emotions and to have conflict-ridden relationships with people you love the most. You may even have experienced self-hatred and how at times rage and anger can push loved ones away. You might struggle with the fear that people will abandon you even when they reassure you that they won't. You may know what it's like to feel so miserable that suicide seems like the only way out of your suffering. It's easy to get discouraged. A moment of intense emotional pain can feel like an eternity. Ask people who don't understand to imagine what 10 minutes of a severe toothache feels like. Very different from 10 minutes of pleasure. Having to suffer through emotional misery on a daily basis leads many people with BPD to think about suicide. However, the reality is that the vast majority of people with BPD get better, and with the right treatment may go on to live fulfilling lives. You can join the ranks of the recovered. You are not alone. Depending on which survey you consult, somewhere between 6 million and 15 million people in the United States suffer from BPD. Sadly, even though BPD is well known to mental health professionals, the general public has barely heard of it. If you are in an outpatient clinic, about 10% of your fellow patients will have BPD. And if you end up in an inpatient unit, nearly 25% of the other patients will meet the criteria for the diagnosis. People often ask about gender differences in BPD. While there is little research on BPD in men, there is growing debate about previous, long-standing data that said that BPD affected women more than men by a ratio of 3:1. Research by Bridget Grant and her colleagues looked at more than 34,000 adults and found that there is no difference in the rate of BPD between men and women. There are a number of theories that try to explain the prior conclusion of a divergence in gender proportions. Some believe that clinicians have a subtle gender bias toward females with regard to BPD diagnosis, but other research has disputed this. Another possibility is that research on the prevalence of BPD is often conducted in psychiatric settings, and because women engage in more self-harming behaviors, there tend to be more women than men with BPD in mental health settings, making it appear that women suffer from this disorder more than men do. So perhaps men with BPD exhibit symptoms like substance abuse or aggressive behaviors that place them in treatment or correctional settings, which are less likely to diagnose BPD. It is our hope that future studies will continue to better define the gender ratios for BPD. At this time, more women than men seek treatment for BPD, so although future research may show that there is an even number of men and women with BPD, in this book you will find more case examples with women than men, in accordance with traditional gender ratios. We hope that all of our listeners will use these case examples and not view them as gender-specific, but rather as illustrations of the challenges that all people with BPD can experience. In the next section, we will examine how BPD is defined. Defining borderline personality disorder. Since 1938, when many of the recognizable features of modern BPD were first described, the criteria for defining BPD have changed. Here we will look at how BPD is seen today, and then characterize it in a way that will be useful beyond today's definitions. In Part 3 of the book, we will expand more on the lived experience of BPD and how mindfulness helps to reduce the suffering associated with the symptoms. BPD and the DSM. The diagnosis criteria for BPD are outlined in the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Health Disorders, DSM-IV-TR, 2000, also known as the DSM. For a person to be diagnosed with BPD, the DSM requires that at least 5 of 9 symptoms be present. One problem with this requirement is that there are 256 possible combinations of symptoms that someone with BPD might experience, which means that you could be in a room with 255 other people struggling with BPD, and each of you could have a different set of symptoms. There are very few, if any, other conditions in medicine where there is so much potential variation. Then, within these 256 possible types, how these people function in life can be very different. So there might be some people with BPD who, despite their difficulties, have stable relationships and are employed or completing their education. Others with BPD have a very difficult time holding on to a job, make repeated suicide attempts, or struggle with impulsivity and have chaotic relationships. For them, visible scars from self-injury and their ways of behaving make it obvious to others that they are struggling with some form of mental illness. As you can see, there can be tremendous variability in the symptoms that someone with BPD has to deal with. The DSM will continue to refine the definition of BPD in updated editions, but regardless, the DSM is considered as reflecting the current professional consensus regarding the definition of BPD. You should also know that almost all professionals making the diagnosis and involved in treatment will use the DSM as a reference in their professional training. The following are the 9 DSM 2000 criteria for BPD and how they might apply to you. Efforts to avoid abandonment. You might have a strong fear that the people closest to you will abandon you. Jamie, a 27-year-old with BPD, explained it this way in therapy. I am unable to be alone, so I do anything to get into a relationship, but then I worry that the person will leave me, so I start to act clingy. The other person doesn't like it when I'm clingy and begins to push me away. I fear the other person will leave, so I get frantic and then sometimes do bad things to myself, like cutting myself. This freaks out the other person, who then actually does leave. But because I can't stand being alone, I find someone new, and the cycle starts all over again. Your fear of abandonment might be triggered by what seems like a minor rejection, like a friend canceling a plan to go to a movie together, or a therapist running 2 minutes late for an appointment. This fear might lead you to become enraged because you feel uncared for or unimportant. To others, this rage seems disproportional to the situation at hand, but for you, the suffering and fear are nearly intolerable. When you feel abandoned, you might resort to reassurance-seeking behaviors, which are ways of acting that provide reassurance that you will not be left. An example of such behavior is calling or texting your friend or therapist so many times that the person feels annoyed by you. Such behaviors can lead to the destruction of relationships and to the very abandonment that you fear. Unstable and intense interpersonal relationships. As with the fear of abandonment, you might also recognize the fear of being alone. Often, out of the fear of being alone, some people with BPD tend to attach rapidly and intensely to others in relationships. You might notice the feeling that you have to know whether the other person feels as deeply as you do, that when you love others, they love you as much, and that when you suffer, they suffer as much. Because people without BPD don't tend to feel emotions as intensely as you do, they will most likely not respond as deeply as you do, which can feel hurtful. When the hurt is intolerable, you might resort to saying some pretty mean things simply to get back at the other person. Saying such things can leave you feeling ashamed and regretful about what you said, which may prompt you to swing from delivering demeaning comments to assuring the other person that she is the most wonderful being on earth. For the person you love who is on the receiving end of these extremes of attacks and praise, life gets pretty unpredictable, and often the person feels that it's too much to handle. These kinds of relationships are stormy and unstable. Identity disturbance. Deciding who you are and what your values are can be difficult. You might notice that frequently you have relatively sudden and unexpected changes in your life goals, interests, romantic preferences, and values. These sudden changes can lead to an erratic employment history, wreak havoc in your relationships, and make you unpredictable to others in your life. Impulsivity. When we talk to people who are seeking treatment for BPD, the symptom they say gets them into trouble the most is impulsivity. Impulsivity is behaving quickly without evaluating the consequences of the behavior. In fact, sometimes it involves even disregarding potential consequences. In BPD, impulsive behavior usually occurs when you have strong emotions or when you are struggling in your relationship. There are many examples of impulsive behavior in BPD, but typically the most dangerous ones are self-injury, drug use, unprotected sex with unknown or casually known partners, and reckless driving. Although these are not necessarily suicidal behaviors, they are dangerous and high-risk behaviors that can seriously affect your long-term health. Recurrent suicidal behavior and self-injury. Although suicide is not the same as self-injury, throughout the book we often mention these two behaviors together because research shows that people who self-injure have an approximately 30-fold increase in the risk of suicide compared with the general population. The risk is substantially higher for women who self-injure than for men who self-injure. Suicide rates were highest within the first 6 months after the first self-harm episode. So even though suicide and self-injury serve different functions, and it is important to recognize that they are usually behaviors with different goals, they are closely linked. A total distinction between suicide and what is termed non-suicidal self-injury, NSSI, has been proposed for future editions of the DSM. Research shows that whereas many people with BPD self-injure, many others do not. And there are people who engage in NSSI who do not have a personality disorder. Therefore, NSSI disorder might appear in the next edition of the DSM characterized by high levels of depression, anxiety, suicidality, and poor social functioning. Like impulsivity, self-injurious behavior is a common reason why people with BPD seek therapy. As you may have discovered, self-injury works very well to help you regulate your emotions so that you are able to calm down, and few things work as well as cutting. Other reasons why some people with BPD cut themselves are to stop feeling numb, and because the physical pain helps distract them from their emotional pain. So you may have discovered a very effective solution for stopping or diminishing your problems, but what you recognize as a solution, other people see as a problem. For many parents, friends, and romantic partners, the idea that you cut yourself is very distressing. This distress often pushes the cutting behavior underground. People with BPD tell us that they realize that cutting is not a long-term solution. With your emotions going up and down, you can feel as if you were being whipped about in the wind, which can make life pretty miserable. Then, if your relationships start to fall apart and life becomes particularly miserable, you can begin to wish that you wouldn't wake up some morning, or to regard suicide as being the only way out. Usually, thoughts of suicide are just thoughts, but they can be persistent and hard to dislodge from your mind. In some cases, the thoughts turn into plans, and the plans turn into suicide attempts. In people with BPD who have been hospitalized, 90% will have made at least one suicide attempt, and 10% will complete suicide. This also means that most suicide attempts are unsuccessful in BPD, and many people feel cheated by or ashamed of their failures and attempts. Sometimes people will accuse you of attempting suicide or cutting yourself as a cry for help, or say that you are seeking attention. Research shows that these two reasons are rarely the cause of self-injury and suicide. Suicide and self-injury, similar but different. Earlier we mentioned that there is a close link between suicidal behavior and self-injury, and certainly in BPD these two behaviors are very closely linked. But as much as they are tied together, they are also separate, and more than 99% of all acts of self-injury are done without suicide as a goal. So how do we separate these behaviors in BPD? Having spent his professional career studying self-injury, Harvard psychologist Matthew Nock has developed a useful way of thinking about these behaviors. Nock defines self-injury as direct and deliberate bodily harm in the absence of suicidal intent. This definition is useful. However, it is also complicated in that many people with BPD have persistent suicidal thoughts, so teasing the two behaviors apart can be difficult. Therefore, although the following definitions have some overlap and are not distinct categories, we use them in clinical work. Self-injury. Although self-injury is not classified into different subtypes, Nock and others have suggested that it varies on a scale from mild, which is a low level of severity and frequency, to moderate to severe, which is a frequent self-injury that often leads to medical impairment and the need for medical attention. One question that loved ones often ask is, why do people hurt themselves? Our clinical experience is very similar to the research findings in that most people hurt themselves for one of the following reasons. Self-injury relieves their emotional pain. It helps them to feel alive or less numb. It helps them to focus their attention away from the emotional pain by moving it toward the physical pain. It makes someone pay attention to their suffering. This is a rare reason. They are addicted to self-injuring and get a rush of energy. They feel that they are bad and in need of punishment. We also see in our clinical work, and others have reported, that simply thinking or acting on self-injury can reduce suicidal thinking. There are many other reasons that people give for self-injuring, but these are the most common. As you can see, there is not a mention of suicide in the previous list of reasons for self-harming. So even though many people who self-injure have suicidal thoughts, these behaviors are not one and the same. Then how do we consider suicidal behavior? Suicidality. Generally, there are considered to be three types of suicidality. Suicidal ideation means having the thought of killing yourself. A suicide plan means considering and planning the specific way you would kill yourself. A suicide attempt means behaving in a potentially self-injurious way in which you have the intention to die. Emotional instability. Unstable mood, along with difficulty controlling emotional extremes, is a defining problem for people with BPD. Your mood can shift in a matter of hours. This can be true of people without BPD, but for people with this disorder, the emotional ups and downs are often powerfully triggered by frustration and interpersonal conflict. It is the intensity of the emotions and how uncontrollable they are that makes them different. It is generally believed that people with BPD feel emotions more deeply and for a longer period and take longer to return to their emotional baseline than do people who don't have BPD.
Sample complete. Ready to continue?